If your GGT levels came back high on a recent blood test, someone has probably asked you, how much do you drink? But assuming a high GGT is a proof of alcohol abuse is one of the biggest medical myths out there. In fact, dismissing it as just an alcohol marker means you might be completely missing a much bigger, hidden warning about your metabolic health. GGT is arguably the most misunderstood test on your entire liver panel. In this video, we are going to break down what it is actually doing inside your cells, why the alcohol link is so flawed, what that hidden metabolic warning really is, and the one clinical mystery this enzyme is perfectly designed to solve. Let's get into it. To understand the confusion, you have to know what gamma-glutamyl transferase, or GGT, actually does. GGT sits on the outer membrane of your cells. Its main job is to help shuttle amino acids across that membrane to build glutathione, which is one of the body's most powerful core antioxidants. While it's present in the kidneys, pancreas and intestines, when GGT shows up elevated on a routine blood test, it's almost always coming from the liver, specifically from the cells lining the liver's biliary drainage network. The key thing to understand upfront is that GGT is a highly sensitive marker, but a poorly specific one. It picks up liver and biliary stress incredibly easily, acting like a hypersensitive biological alarm. But because lots of different things can trip that alarm, assuming it's always alcohol is when the confusion starts. So why does everyone associate GGT with drinking? Because alcohol is a genuinely potent inducer of GGT. When the liver is exposed to chronic, heavy alcohol use, it experiences significant oxidative stress. To defend itself, the liver switches on more GGT production to try and ramp up its antioxidant supply. This happens independently of any actual liver cell death. Plus, alcohol can cause mild inflammation in that biliary drainage network, driving GGT up even further. The numbers do back this up. In people with chronic heavy alcohol use, usually defined as more than 50 to 80 grams per day, GGT is elevated in roughly 52 to 94% of cases. But here is the catch. Clinically, those numbers are a mess. If we set the cutoff low to catch everyone, the test is only about 48% sensitive, and 70% is specific. If we push the cutoff higher to be absolutely sure it's alcohol, we miss a massive number of real cases. There is simply no single cutoff that is both highly sensitive and highly specific for alcohol use on its own. And that mediocre specificity is the real problem, because plenty of things that have nothing to do with drinking will trip the GGT alarm. Fatty liver disease is one of the most common causes of a mildly elevated GGT today. We covered this in a previous video. It's driven by metabolic factors like insulin resistance, entirely unrelated to alcohol. Anticonvulsants like phenytoin, carbamazepine and phenobarbital are potent liver enzyme inducers. They switch on GGT production the exact same way alcohol does, through enzyme induction, not injury. It's a benign, expected reaction. Bile ducts problems, gallstones, strictures, or any kind of physical blockage to bile flow will drive GGT up sharply, usually alongside a rise in ALP. Here is an underappreciated piece of GGT research that most people miss. Even when GGT is within what we consider the normal reference range, higher levels have been consistently associated in large population studies with an increased future risk of type 2 diabetes, metabolic syndrome, and cardiovascular disease, independent of alcohol intake. Why? It ties right back into GGT's actual physiological job, recycling glutathione. Studies indicate that a high normal GGT reflects greater oxidative stress and antioxidant demand at a cellular level. It tracks with the chronic low-grade inflammation that drives insulin resistance and vascular damage. Now, this doesn't mean a slightly elevated GGT is a cardiovascular diagnosis. It's population-level data, but it's a perfect example of how a single lab marker can carry deep biological meaning well beyond the organ system it's traditionally filed under. So if a GGT is a weak standalone alcohol marker, what is it actually good for? This is the one application that rarely gets talked about but is incredibly useful in the lab. It's used to interpret another liver marker. Alkaline phosphatase, or ALP, is another enzyme that comes from two main sources, the liver's drainage network and your bones. So when your ALP comes back high on its own, there is a real question: is this a liver problem or is it a bone problem, like a fracture or a growth spurt? Because bone doesn't produce meaningful amounts of GGT, GGT solves the mystery instantly. If ALP is high and GGT is also high, the problem is in the liver or bile ducts. If ALP is high but GGT is normal, it points away from the liver and toward the bone. That is the single most well-established, clinically important role of GGT, and it has nothing to do with drinking at all. Now, none of this means GGT is useless for monitoring alcohol. It's just not a verdict on its own. In clinical and research settings, we combine it with other markers. Carbohydrate deficient transferrin, or CDT, is a classic pairing that substantially improves specificity. More recently, we look at a direct biomarker called phosphatidylethanol. This is a lipid that only forms in the presence of ethanol. Unlike GGT, it cannot be confused by fatty liver or medications. But GGT does have another genuinely practical utility: its half-life. It has a relatively long biological half-life of roughly 26 days. Once someone stops drinking, an elevated GGT takes several weeks to fall back toward baseline. This makes it incredibly useful as a trend. A steadily falling GGT over consecutive tests is a genuinely reassuring sign of sustained abstinence or reduced intake, which is exactly how it's used in clinical monitoring programs. So if you're looking at your own single result, here is the honest takeaway. A high GGT is a signal that something is affecting the liver or bile ducts. But jumping straight to "this means I drink too much" skips over fatty liver, medications, and biliary causes that are just as plausible and often more likely. So a quick recap. GGT is highly sensitive but poorly specific. It's associated with heavy alcohol use, but fatty liver and medications can raise it too. It carries a genuine signal about cardiometabolic risk, and its absolute best diagnostic use is confirming whether a high ALP is coming from the liver or bone. If you haven't already, go watch my full breakdown of liver function test. It's the perfect companion to this video and will be linked in the description. If this cleared up a common misconception for you, hit subscribe and share the video. With that said, thanks for watching and see you in the next one.